Hey everyone, and welcome to this explainer. Today we're unpacking a really high-yield critical care breakdown from Dr. Kwong ICU. We are totally demystifying what can sometimes feel like an intimidating skill, measuring cardiac output using point-of-care ultrasound, or POCUS. Whether you're trying to optimize fluid resuscitation or you're managing vasopressors down in the ED or the ICU, this guide shows us exactly how to replace sheer guesswork with hard quantitative data. We're going to take something that seems mathematically complex and break it down into this incredibly easy visual process. Let's get into it.
Okay, let's dive into our roadmap real quick. We'll be covering 1. The cardiac output code, 2. The cylinder concept, 3. Measuring LVOT diameter, 4. Capturing the VTI, and 5. The final calculation.
Section 1. The cardiac output code. Let's look at understanding undifferentiated shock.
Now, historically, getting this kind of hemodynamic data, it was a massive ordeal. Early clinicians literally had to rely on fixed principle using thermodilution with a pulmonary artery catheter. Invasive? Yes. Time-consuming? Very. And potentially pretty dangerous for the patient. But then fast forward to the 1980s, and sonographers totally changed the game with Doppler-assisted calculations. Suddenly, out of nowhere, we had a non-invasive, super rapid, and just incredibly accessible way to estimate cardiac output right at the bedside.
So the crucial point this source makes here is making sure we know what we're actually trying to find, right? Cardiac output is, simply put, the total volume of blood moved by the heart in one single minute. And the foundational formula? It's just basic multiplication. Cardiac output equals stroke volume times heart rate. Stroke volume is the amount of blood pushed out in one beat, and heart rate is, well, how many beats happen in a minute. We almost always already know the heart rate, so the real puzzle this guide helps us solve with our ultrasound probe is tracking down that elusive stroke volume.
Which brings us to Section 2, the cylinder concept. This is all about simplifying stroke volume.
The material presents a massive aha moment here. Stroke volume is simply a cylinder of blood leaving the left ventricle through the left ventricular outflow tract, or LVOT. To figure out that volume, we just use basic high school geometry. Think back to math class. We need the width of the cylinder, which is our LVOT diameter, and we need the length. In this case, the length is the literal distance a single blood cell travels in one heartbeat. We call that length the velocity time integral, or VTI. So you get the width, you get the length, boom, you've got your volume.
Real quick, before grabbing those measurements, the guide notes how to prep. The patient should be supine or in the left lateral decubitus position. You absolutely need a phased array probe, and make sure you select that cardiac exam preset. One major technical note here, your machine absolutely requires pulse wave Doppler capabilities and a cardiac calculation package. Most of your standard cart-based hospital machines have this for sure, but some of those super basic handheld devices might not.
Section 3. Measuring LVOT diameter. Let's find that cylinder's width.
The guide breaks this down into 3 super methodical steps. Step 1. Obtain a really clear parasternal long axis, or PSLA view. Step 2. Freeze your screen right at mid-systole. Why then? Because that's exactly when the aortic valve leaflets are completely wide open, giving you the true maximum width. Step 3. Use your measurement tool right near the aortic annulus. And the source drops a fantastic pro tip here. Use the machine's zoom feature. It makes identifying the exact base of those leaflets so much easier and way more accurate.
Now, what's really interesting here is this clinical rule of thumb. A normal LVOT diameter in your average adult is typically right around 2 centimeters. Keeping this benchmark from the text in the back of your head is just a great way to ground your expectations. If you measure, say, 1.9 or 2.1, you're right on the money. But if you measure 4 centimeters, no way. You instantly know your calipers are in the wrong spot and you need to adjust your view.
All right, Section 4. Capturing the VTI. Finding our cylinder's length.
This part is also broken down into 3 straightforward steps. First, grab the apical 5-chamber view, where that aortic root opens up right dead in the middle of your screen. Second, place the pulse wave Doppler gate right at the LVOT, exactly at the base of the aortic valve leaflets. And third, activate your Doppler, hit freeze, and carefully trace the bright outer edge of that systolic waveform. The machine then calculates the area under that curve, which magically gives you the distance in centimeters.
But listen, the material stresses this next point absolutely heavily. Ultrasound physics relies on angles. Your Doppler gate and the blood flow must be as parallel as humanly possible. If your angle is off, you risk artificially lowering the measured velocity,
which means you are severely underestimating the patient's cardiac output. Oh, and the guide also warns that while those auto trace features for the VTI on modern machines are super convenient, you should always eyeball them. Just make sure the computer actually captured the outline accurately.
Next up, the guide shares an absolute game changer of a POCUS cheat code, the number 20. Think about it. If you run that cylinder formula in reverse, using a 2-centimeter diameter and a normal 60 milliliter stroke volume, a normal LVOT VTI comes out perfectly to about 20 centimeters. Memorizing those two numbers gives you an instant, built-in reality check when you're at the bedside scanning.
And beautifully enough, that number 20 shows up again in the literature. Dr. Ved Din, POCUS 101 editor, noted from a study that it takes exactly about 20 practice measurements until you start getting reliable, reproducible results. The huge takeaway here? Keep practicing. Don't get discouraged because your 20th scan is going to be drastically better than your first.
Section 5. The final calculation. Let's put it all together.
So that final variable we need? Heart rate. And it's incredibly easy to grab. The source notes you can just use the ultrasound machine's cardiac package, which usually means measuring peak to peak between the Doppler waveforms, or honestly, just glance up at the bedside patient monitor and punch that number directly into the system. Simple as that. And this brilliantly illustrates the complete mathematical matrix. Step 1 finds the area. Step 2 multiplies it by the VTI to get stroke volume, and Step 3 multiplies that by heart rate. The ultrasound machine literally does all this math automatically once you enter the data. But, as the guide highlights, understanding these underlying mechanics is what removes all the mystery. You know exactly what the machine is calculating behind the scenes. So, the final question the material leaves us with is this. Are you ready to replace clinical guesswork with hard, quantitative ultrasound data? The next time you encounter a patient in shock, remember that cylinder concept, remember the number 20, and go get the data you need to save a life. Thanks for exploring this with us, and I'll catch you in the next explainer.